There are. In this lecture, we're going to explore drugs that produce anesthesia. There are, of course, two major types of anesthesia. General anesthetics that are usually used during major surgeries where we want the patient to lose consciousness and not remember what happened, as opposed to local anesthetics where the patient usually remains conscious, but we're trying to anesthetize a specific part of the body to allow a surgical procedure and so forth. So let's get started with general anesthetics, and then we'll segue over later to the local anesthetics. So what is general anesthesia? The drugs we're about to see, their goal is to have the patient not perceive any sensations, to either be unconscious or to have their consciousness altered sufficiently so they're not aware of what's being done to them or what's happening to them. The purpose, of course, is to allow usually a detailed surgical procedure. Major surgeries like open heart surgeries, hip replacements, and other joint replacements, and other detailed surgical procedures can then be performed with minimal harm to the patient. So let's take a look at how we can achieve this. Now, before we get into the actual drugs, we want to talk a little bit historically. Before 1846, patients were often made unconscious by strangulation or a blow to the head. Drugs might be used if a patient could afford them, things like alcohol and opium. But most of the time, there was no chemical intervention. The patient was simply restrained physically by several large assistants to allow a surgical procedure to be performed. And the procedures were, rather barbaric. Amputations, draining an abscess. We were not going to see real delicate surgery done under these conditions where the patient is basically fully conscious. So what changed after 1846? It's a famous story. On October 17th, in 1846, at Massachusetts General Hospital, was the first demonstration of general anesthesia. And it was actually done by a dentist, William Morton, who had been using ether to anesthetize his dental patients to do tooth extractions and other procedures. And he reported this fact to the medical community, so they invited him to give this demonstration. And the story's been told and retold. And it was a really amazing breakthrough for the medical community. This idea that you could purposefully make a patient unconscious at your discretion. This at the time was completely unheard of. So it was a very big breakthrough to do this. So again, after 1846, we saw the first use of ether. But ether, of course, is rather toxic. It's obviously flammable. So since then, we've been steadily developing safer and less toxic anesthetic drugs. So what do we want out of a general anesthesia? Requirements are loss of consciousness, or again, at least perceived sensations. Amnesia. Patients should not remember what happened during the surgery. Inhibition of reflexes. And we're not just talking about deep tendon reflexes. We want to inhibit the cardiovascular reflexes that might alter blood pressure during a surgical procedure. So all reflex activity should be blunted. Muscles should be relaxed. We don't want the patient to suddenly have a muscle contraction in the middle of a delicate surgery. And we'll see later that we often use other drugs to help achieve this, the so-called muscle paralytics. And of course, it should be safe, transient, and predictable. We want the patient to recover in a fairly short period of time from the anesthesia and not really have any residual effects of the anesthesia. And as I indicated, this has gotten better and better over the years from the original inhaled anesthetics like ether and chloroform. So we're going to see that anesthesia has really come a long way. And a lot of the anesthetics now really meet these requirements quite well. When a patient is about to undergo anesthesia, they often undergo or go through these characteristic phases or stages of anesthesia, starting from fully conscious to the first stage, which is analgesia. They don't feel pain. As they become more anesthetized, they undergo excitement or delirium. This is not a good thing. Oftentimes, this patient is prepped for surgery, and the last thing we need is the patient thrashing around and becoming delirious. So we'd like to get through this stage quickly into the third stage, which is the so-called stage or plane of surgical anesthesia. And there are several subcategories of this stage, but this is the desired level of anesthesia. If a person becomes too anesthetized, they can undergo medullary paralysis, where the control centers in the medulla, respiratory and cardiovascular control centers, become paralyzed. This is not good. So what we'd like to do is go from fully conscious to stage 3 as quickly as possible. Stay in stage 3 just as long as possible, not advance too far into stage 4, and then come out of the anesthesia quickly too. And as we said, the newer anesthetics are much better at doing this, and we'll see that we can mix and match different anesthetics to do this, to get from conscious to stage 3 quickly, and then back out of anesthesia quickly. So what are our types of general anesthesia? We can grossly classify them depending on how they're administered. We can talk about the inhalation agents. These are the halogenated liquids like halothane and enflurane. Nitrous oxide is again inhaled. It's very short acting, oftentimes used during dental procedures, and various other gases. Then we have the injected, and there's a diagram of halothane. We have the injected anesthetics, which are typically given IV, and this is where the barbiturates are very well used. Drugs like secobarbital and thiopental. The benzodiazepines in liquid form can also do this. And even the opioids in a higher dose of liquid form can be injected IV to cause a general anesthetic effect. Question then is, why use one group over the other? And the answer is, oftentimes you use both. That's what we'll see in the next slide.
Press pause and read the following question before proceeding to the next slide for the answer. Press pause and read the following question before proceeding to the next slide for the answer.
So in terms of the choice of anesthetic, we're going to often see 2 or more drugs used to provide what's called balanced anesthesia, taking the advantages of different types of drugs and different routes of administration to give a nice balanced effect and, as we saw earlier, get that patient into the right stage of anesthesia quickly and then allow them to come out to maintain that stage as long as necessary, but then come out of it quickly too. So a traditional method is to use an injected agent, like a barbiturate, thiopental in this case, a small amount, just enough to get the patient under. Of course, when this is injected, we see the patient, or maybe you've had surgery, they ask you to count backwards from 100, and you know this drug will take effect when injected very quickly, within seconds. But just give enough to get the patient under the anesthetic effect. And then follow that by switching over to an inhaled agent, one of the enflurane halothane type drugs, and keep the patient there on this inhaled agent for the rest of the surgery. This gives us real advantage because the injected agents, again, the advantage to the injection is we'll get the patient under the anesthesia very quickly, but by just giving a small amount, we don't want to overdo it. The disadvantage of injecting is if you give too much, it can have many adverse effects that you kind of have to ride out. You don't really have a way to resolve that. The inhaled agents, they take effect more slowly, so we wouldn't want to maybe start from fully conscious and have the patient inhale the drug. The advantage of the inhaled is that they can be regulated very carefully by adjusting the amount of anesthesia, the breathing rate, the amount of oxygen supply. So that gives us this nice synergy between these two methods. Small amount to get the patient under, and then switch to an inhaled to keep the patient under. However, there are many other combinations, additions, depending on the length of the surgery, the patient's medical status, comorbidities, does the patient have cardiovascular or pulmonary issues? So the anesthesiologists have really worked hard to do this, to really tailor the type of anesthetic regimens based on all of these other factors. So it's not just a cookbook effect or one size fits all or one method of anesthesia for every patient for every type of surgery. So once again, this has really evolved into a really important aspect of a surgical procedure. An important question over the years has been, how do these drugs work? How can we purposefully and predictably decrease consciousness in the central nervous system? What we're going to see is some of these drugs increase inhibition or decrease excitation throughout the CNS by either direct effect on the lipid bilayer, by an effect on neuronal receptors, like the GABA receptors, the opioid receptors, or a combination of these two effects. We'll see that schematically in the next slide. But the whole idea is we're trying to, maybe at the same time, do both things. Get more inhibition, get less excitation, especially through the parts of the brain that control consciousness and alertness. But again, let's take a little closer look at this idea. This diagram represents a neuronal membrane in the CNS, especially in a part of the brain that controls consciousness and level of alertness. Many drugs that we're meeting here are lipid soluble. Some of the classic anesthetics are very lipid soluble, which generated this so-called lipid effect theory. Here on the left side of the diagram, the black diamonds are representing the drug. They would become, thought is, the drug would be embedded in the lipid bilayer, and it would disrupt this bilayer. And by doing so, it would affect the opening and closing of ion channels, shown in the middle of the diagram. And again, this was based largely on the fact that these drugs are very lipid soluble. Another theory is that the drug binds specifically to the receptor of that channel that's located in the membrane. The idea here being that it either inhibits the channel or it excites a channel that causes inhibition. So by blocking this channel or by affecting channel activity that controls neuronal excitability, we'd get neuronal inhibition. As this theory is probably more predominant now. In other words, the ion channel effect is probably a more predominant idea, because we know now that most anesthetics do this to some extent. We know it's very true for some anesthetics, like GABA, like the opioids. But even still, we can't rule out the lipid effect either. And it may in fact be a combination, where some anesthetics drugs do both at the same time. So this slide is summarizing all the different ways these drugs could affect different receptors. And as I said, we're starting to see more of a tendency to believe these drugs invariably exert some, if not all, of their effect on a neuronal receptor. Benzodiazepines on the left side, for instance, definitely affect the GABA receptor. Barbiturates likewise affect the GABA, as well as maybe the glycine receptor. Towards the right side, you can see other ion channels, like the potassium channel, the acetylcholine channel, this N-methyl D-aspartate channel or receptor, and even the opioid receptors. So again, some of these receptors increase inhibition, shown to the left side of the diagram. Some of them decrease excitation. Those are shown to the right side of the diagram. So it's likely that these drugs, as you can see here, are affecting one or more of these channels to cause inhibition or decreased excitation throughout the central nervous system, and that's most likely why they cause an anesthetic effect. Now, anesthetic adjuvants are helpers, drugs that are given with or just before the anesthesia to allow a better balanced effect of the anesthetic. So we know that several drugs are commonly given preoperatively or postoperatively to relax and sedate the patient prior to the surgery, reduce postoperative nausea and vomiting, often abbreviated PONV, and reduce other problems related to the anesthesia, depending on what type of anesthesia and other problems the patient may have. The next slides show a little more detail about this, about which drugs can be given. So here we see a chart of some common helper drugs, adjuvants to the general anesthetic. On the left, for instance, the barbiturates. They can be given to decrease anxiety, to allow a better induction or beginning of the anesthesia. So drugs like phenobarb, secabarb are really good for this. The opioids are nice because they can decrease pain before the surgery at the same time that they decrease anxiety and cause some sedation. You can see fentanyl, meperidine, and so forth. And if you work your way down the list, you see some other drugs given for various reasons. Benzodiazepines, likewise, anxiety, sedation, amnesia, antihistamines, reduce vomiting as well as cause sedation, anticholinergics. They were really important because in the past the anesthesics caused a lot of increased salivation, which could cause respiratory secretions to increase. That's reduced somewhat by the newer anesthesias, but still, they can be helpful for that, and they can be helpful to decrease the post-op nausea and vomiting. H2 receptor blockers, these are drugs like Tagamet and Pepcid. They decrease gastric acidity, so that if there is some aspiration of gastric contents, there's less chance of causing aspiration pneumonitis. And finally, the 5-HT3, these are serotonin receptor blockers. Serotonin, by affecting these receptors, does increase the nausea and vomiting post-op. So these have been very helpful. So clearly this is a long list of possible drugs that are worked somewhere into the surgery, either obviously some of them pre-surgery, some of them post-surgery. And it's, once again, helping our patients go into the surgery more relaxed and then recover better after the surgery. Another important helper drug are the neuromuscular junction blockers. These drugs are used to paralyze skeletal muscles. They're not muscle relaxants, although some people do call them that. They're really paralytics. They are going to block the neuromuscular junction receptor, and this will allow the patient to be better positioned on the operating table. They'll prevent spasms that could be disastrous during a delicate surgery. And of course, they allow easier mechanical ventilation because they relax the chest wall and the patient's not trying to fight the ventilator. There are two ways to do this. We have a depolarizing blocker like succinylcholine. It binds to the acetylcholine receptor, depolarizes it, but does not allow it to recover, so the muscle can't be excited. The non-depolarizing are true blockers. They bind to the acetylcholine receptor, and they don't let acetylcholine activate that receptor. So there are different options here, again, being chosen by the anesthesiologist based on the patient's needs, the length of surgery, and so forth. These drugs are usually a short duration of action. The effects are usually over long before the surgery is over. Other doses can be given during a long surgery, but they typically last anywhere from 5 to 10 to 30 minutes or so. Some patients, however, may genetically lack the enzymes needed to metabolize these drugs. If so, the surgery ends, but the patient remains paralyzed. And we will see this occasionally. Patient has to be in the ICU and mechanically ventilated because the body has to eliminate the drugs, oftentimes through excretion in the urine, and that takes quite some time for some patients. So most patients, these drugs are long gone before the surgery ends, or certainly by the time the surgery ends. But once in a while, we will see the situation where a patient does not recover from the drug, and they have to let it run its course. And of course, then the patient has to be mechanically ventilated until that occurs. The effects can be reversed somewhat by cholinesterase inhibitors. If the drug blocks the acetylcholine receptor, these drugs like neostigmine, idrophonium, or other drugs that actually inactivate the certain drugs in this group, like recuronium and vicuronium, those are two of the depolarizing blockers. So there are things that can be done to help speed up this process. And once again, you may see this done in a patient that comes out of the surgery, but the neuromuscular junction blocker is still in effect. The other important thing to realize here, you don't see it on the slide, is that these drugs, they don't cause anesthesia. And if the anesthetic wears off while these drugs are still in effect, the patient is fully conscious but can't move. And we hear these harrowing stories from time to time about a patient being awake during surgery. So it's really critical when a neuromuscular junction blocker is in effect that an adequate amount of anesthesia is also being administered. And the anesthesiologists are very aware of this, and hopefully are taking a lot of safeguards to prevent this, to make sure the anesthetic doesn't wear off before these neuromuscular junction blocker drugs will also wear off. Now, a quick word about something called dissociative anesthesia. Here, the patient may look like they're conscious. Their eyes may be open. They may be talking or responding to simple questions, but they're indifferent or unaware or dissociated from what's happening around them. It's typically achieved by using a strong drug called ketamine, or a combination of an antipsychotic, droperidol, with a strong opioid like fentanyl. And this is sometimes helpful in diagnostic or radiological procedures, things like a colonoscopy, or dressing changes in severe wounds or burns, or in emergency surgeries. If a person has eaten and has food in their stomach, we're always nervous that they're going to aspirate the contents of their stomach and maybe during the surgery. And that usually is a limiting factor to a general anesthetic, so they might do this type of dissociative anesthesia. And they do this sometimes with kids too, with children undergoing surgical procedures. So I just bring it up because you may be working with a patient while they're undergoing dressing changes and so forth, and you may see this done from time to time. So what are our major concerns? Most of the time, when a patient is undergoing a really extensive surgery, like a hip replacement, we're not there while the anesthetic is being administered. However, sometimes we are. I mentioned that some of these techniques are used during burn debridement and other dressing changes, so we may see a patient or work with a patient while they are under an anesthesia, especially that dissociative type we just saw. But more often what we have to do is deal with the residual effects of the anesthesia. So respiratory hygiene becomes important. Secretions can collect in the respiratory tract during these long surgeries. Most of the time the patient is intubated as well, which can stimulate secretions within the respiratory tract. So we want to make sure the patient is clearing out secretions, doing deep breathing techniques, can work with the respiratory therapy staff to ensure that they're using the incentive respiratory devices that are sitting by their bedside. Second thing, short-term confusion and lethargy. This is due to that redistribution effect. While the patient is under the anesthesia, because it's very lipid soluble, has been soaked up by fat content in the body, and now it's leaking out of these fat deposits and back into the bloodstream. So we see this, and we hopefully can try to speed it up a little bit by getting the patient moving, by doing respiratory exercises to get them to breathe more deeply. The last thing is probably the most concern of all, is that we sometimes see a patient start to have these long-term effects on cognition and intellectual function. A patient goes into surgery, and when they come out, the family will often say, there's something different here. Their personality is different. Sometimes it's pretty profound, and the patient is almost hallucinating and almost psychotic-like. That's different. That's a little more serious, and that could be due to some neuronal death that occurred during the anesthesia. But what we're talking about here is really more subtle changes in cognition, behavior, intellect. And they're studying this very carefully because this may be so gradual, and it may continue on for several months after the anesthesia event. So there's a lot of concern about this now. Patients, when they come out of surgery, something has definitely changed. So stay tuned for this. We're just starting to get a better sense of this, and that again, because these changes can be long-term and can be rather gradual, we're just not sure why or how it occurs, and possibly and eventually how to prevent it. Now we're going to get into the local anesthetics. These are not the same drugs we just saw applied locally. They're a whole different set of drugs. But they are, as you can see, usually applied locally, with the goal being to interrupt nerve conduction at a specific site of application. We don't need to make the entire patient unconscious, but just anesthetize a specific part of the body. with the purpose being to prevent or relieve pain without loss of consciousness, and hopefully without systemic effects on the heart, the lungs, the kidneys, and other organs and tissues. Typical local anesthetics are pretty similar to each other chemically, and they tend to have this caine suffix. So drugs like lidocaine, procaine, bupivacaine, and so forth, they're structurally similar. You can see the structure of lidocaine here has a lipophilic group on one end, a hydrophilic group on the other, and they're connected by this intermediate chain. So these drugs are sort of like a key that's going to fit into a lock, the lock being on the neuronal membrane to shut down activity on that neuron. We'll see how that works in just a second. Now, how do these drugs work? They work because they bind to sodium channels in nerve membranes that are located on the axon of the nerve. And when they do this, they inactivate that sodium channel. And if we inactivate a few of these channels in a row, we're not going to be able to get the action potential to be conducted past that point. They're like a roadblock. And you can see on this diagram, on the left side, the sodium channel is open. Sodium, of course, enters, and it's that entry of sodium that propagates or conducts the action potential down the membrane. But the local anesthetic, probably by binding to the inner opening of this channel, acts again like a key and locks this channel into a closed position. And clearly no sodium is going to get into that channel. So it can't perpetuate, it can't prolong or propagate this action potential down that nerve cell membrane. We'll see this a little more schematically in the next slide. So here you see an axon, the red structure, and there are sodium channels all along the surface of the axon. When an action potential comes down this axon, sodium enters these channels, and again it recreates at each step of the axon a new action potential, basically, to keep this action potential going the entire length of that axon. The local anesthetic acts like a cork or a key to lock these sodium channels closed, so that now when an action potential comes down the neuron, it can't get past that point. And there's that roadblock effect. And you don't have to do this to the entire length of that neuron. You just have to do it for a specific length. Fairly short, maybe 2 to 3 nodes of Ranvier in a myelinated neuron. And that's enough of a roadblock that that action potential cannot get past that point. Now we're going to get into clinical use of local anesthetics according to the way they're administered, starting with topical, then transdermal. Infiltration, we'll talk about what that is, nerve block, spinal epidural, a sympathetic block, and finally something called intravenous regional anesthesia. So we're talking about these drugs being administered in specific ways to achieve certain goals. So let's get started with these. So first of all, we have topical. And topical means you apply the drug to the surface of the skin, typically to treat a problem on the skin. Minor burns, abrasions, other types of wound care. If a person's ever sprayed something like Solarcaine, a commercial product, on their skin, you've applied a local anesthetic topically. We may also see this done prior to injections or inserting an IV line to anesthetize the skin so it's not so painful to do the second injection. There was some suggestion about using these drugs in spasticity to help prevent afferent input from creating a spasticity condition. Original studies were quite conclusive that this might be beneficial, but it never really caught on as a common treatment. But we do see, again, these drugs used very common topical application for minor skin issues. Transdermally, we're going to apply it to the surface of the skin and then try to enhance it to move through the skin by either using electricity. We use this, of course, in clinical practice using iontophoresis techniques, or using ultrasound, using phonophoresis techniques, ultrasound energy to make the drug go through the skin. And this is done by some practitioners to, again, decrease pain in a specific part of the body. Here you're seeing the active electrode applying a local anesthetic to the patellar tendon. Uh, it's not a bad intervention if we understand that the local anesthetic is not going to treat the problem. It's only an anesthetic. And I always make the case it'd be like going to a dentist, getting a shot of Novocaine, and then leaving. You're not really solving the problem. So if we're going to do this, if we're going to apply local anesthetics through these transdermal techniques, either iontophoresis or phonophoresis, it should be as a means to an end so that we can then apply a more aggressive treatment, maybe some transverse friction massage or some exercise technique. But my point is, just applying a local anesthetic does not really help solve the problem or improve the situation that's causing the pain in the first place. Other chemicals can also be applied with the anesthetic to enhance their movement through the skin. And they're called just that, enhancers. So local anesthetics themselves aren't usually permeable to intact skin. And these other chemicals or these other physical techniques, electricity and ultrasound, may help improve the movement through the skin. We do, however, see patches used as well. Lidocaine patches can also be effective in putting the drug with these other chemicals into a nice patch form, very convenient, to allow it to move through the skin. And that's what's shown here, this idea of putting lidocaine in a patch, applying it over a surface of the skin to a part of the body that's in pain. And what we're really doing is just getting a local anesthetic effect. Once again, it can be very helpful. It's very popular among some patients and practitioners. It's not really solving the problem, but it can be symptomatically helpful. Some of these patches have combined the electricity technique with the patch. And we have these patches that have a low level of electrical current, sort of like an iontophoresis device that's included right in the patch. But once again, some of them are passive, that's what's shown on the left. Some of them are more active and can use electricity to enhance the movement of the lidocaine into the skin. So it's a nice technique, and again, some patients really like this idea.
Press pause and read the following question before proceeding to the next slide for the answer.
Infiltration is injecting the drug subcutaneously, typically around the site of a selected area, to allow the drug to spread into or infiltrate into or penetrate the area you need to be anesthetized. This is the common technique that's done before suturing a wound. Going to inject the drug around the outside of the wound, let the drug, again, filter into or penetrate into the wound area so that the wound itself can be sutured without causing a lot of pain. So that's the most common time we're going to see infiltration used. A peripheral nerve block, we're injecting the anesthetic near a nerve or a group of nerves, a nerve plexus. Commonly used for dental procedures. If a person does get a shot of Novocaine at the dentist's office, they're getting a peripheral nerve block. Other minor surgeries, including things like carpal tunnel surgeries, can also use this technique. Now, make sure it's clear that we're not injecting the drug into the nerve. You don't want to do that. That would damage the nerve tremendously. But inject it around the nerve, allow the drug to penetrate into the nerve bundle, and cause anesthesia, again, by blocking sodium channels in the axons that are contained in that nerve. So peripheral nerve block, very common for a lot of different procedures. Now, a spinal epidural block is applying the drug around the spinal cord. An epidural, by definition, is outside of the dura. A spinal is putting the drug into the subarachnoid space. So, the needle has penetrated the outer layer, the dura mater, the second layer, the arachnoid layer, and then the drug ends up into the subarachnoid space. And on the left side of this diagram, you can see those two techniques. The epidural, the upper needle, is not penetrated through the meninges, whereas the second needle, the spinal nerve block, has done so. Both are very valuable in producing anesthesia below the point of application. We see them done for certain lower extremity surgeries or to apply anesthesia during childbirth. and especially cesarean sections. An epidural, a little bit safer. It does not penetrate the meninges, so there's less chance of meningeal tears and meningeal bleeds or direct damage to the spinal cord tissue or the cauda equina. Spinal provides a much stronger block because the needle is getting closer and it's already penetrated through the first two layers of the meninges. So selection of one over the other is based on, as usual, the patient's needs, the type of surgery or procedure that's being done. A sympathetic block involves injecting the drug around the sympathetic chain ganglia, either the stellate ganglia in a patient that maybe has upper extremity pain, or the L4, L5 sympathetic ganglia for a person who has lower extremity problems. And this was done routinely for conditions like what we used to call RSD, reflex sympathetic dystrophy, what we're now calling complex regional pain syndrome. The idea being to interrupt the outgoing sympathetic discharge to that extremity, either the arm or the leg, with the intent that there's been some increase, something has caused a hyperactivity or an excessive discharge of sympathetic activity to that extremity. And by interrupting it, even temporarily, we may help resolve some of the vicious cycle that's causing this excessive sympathetic discharge. So you may see this done. It's usually a series of injections, again, either into the neck or into the lower abdomen to try to interrupt this sympathetic discharge. And finally, this last method of administration is called an intravenous regional anesthesia, or simply a beer block. Here, the local anesthetic is injected into the venous system of the affected extremity, either the arm or the leg. We have to keep this drug in that extremity. We'll see in a minute that these drugs can be actually very toxic if they reach the heart and the brain. So a tourniquet is placed proximally on the limb to keep the drug in that limb for a period of time, usually about an hour or two. This has been used quite a lot to do some surgical procedures to that extremity, or to treat problems like complex regional pain syndrome, what we used to call RSD, reflex sympathetic dystrophy syndrome. We're trying to keep that anesthesia in effect in that extremity, as I said, for an hour or so, to try to obviously anesthetize the limb to allow a carpal tunnel procedure or some procedure on the foot or the ankle, or to try to, again, delay or shut down sympathetic discharge to that extremity because it's hyperactive. So beer blocks have become very popular for both of these procedures. Again, it's a local anesthetic that's being retained in that extremity for a specific period of time to allow these procedures or this effect on the sympathetic discharge to occur. This is showing how a beer block is done. We see the tourniquet in the upper part of the diagram with an IV running down into a vein in the hand. A lot of times it's injected. We see the extremity wrapped, again, to help retain it in that extremity. This is a patient receiving it. Again, you can see the tourniquet proximally on the patient's arm, the IV being applied into the vein on the back of the hand. So, a little trickier to do, but some of the anesthesiologists have really advocated this for several conditions. We want to talk about something called continuous nerve block because it's become very popular in patients recovering from surgery. Here, a small tube or catheter is implanted near the peripheral nerve to a specific part of the body. For instance, the femoral nerve that's supplying the knee joint. And the local anesthetic is dripped slowly, continuously onto that nerve. Once again, we're not putting the needle or the catheter directly into the nerve, but very close to it, so that this anesthetic can continuously bathe the nerve and maintain that effect, that anesthetic effect. And it allows excellent postoperative pain control because it's an anesthetic. It's not an analgesic. That patient will not feel their leg or their arm. So that's why they've become very popular in things like knee joint replacement or other knee surgeries like ACL repairs. The patient is not getting the wooziness and confusion and sedation that they would from something like an analgesic opioid drug that affects their brain as well as while it's trying to control pain. So the patient is alert, they're conscious. The drawback, of course, they don't feel that extremity. And if this is the lower extremity that's being affected, we have to make sure that we have to brace the knee or protect the knee, because if the person puts weight on that leg, the knee is probably going to buckle. Again, the patient cannot feel their extremity while this block is in effect. So even though they've become very popular, we have to be careful. And if we are doing some intervention to that extremity, some range of motion, what have you, be a little more gentle, because again, the patient will not feel this extremity. Here's a common example of how a nerve block could be used. What you're seeing here is a catheter being inserted near the femoral nerve. You're seeing a patient's thigh here. A small tube is being inserted to allow post-operative pain control after a knee replacement, knee arthroplasty. Once again, patients like them. The docs love them because they don't have an effect on the patient's alertness or their cardiovascular function or respiratory function. We have to be careful. That patient's knee has to be braced if we're going to try to get this patient on their feet. And other institutions have other protocols about not allowing weight bearing until the person can voluntarily extend their knee and activate their own quadricep, especially after the nerve block has been removed. So they're typically in effect for a day or two after the surgery, and then even after it's removed, we have to make sure that that patient can activate their own quadriceps voluntarily before they try to put weight on that leg.
Press pause and read the following question before proceeding to the next slide for the answer.
We should talk a little bit about something called differential nerve block. This is where not all fibers in that nerve or axons in that nerve are affected in the same way by the anesthetic. What we see is the smallest non-myelinated fibers are usually affected first, with the largest myelinated fibers affected last. So the typical order of functional loss, when an anesthetic is applied, pain is affected first. We have an analgesic effect first because, again, these are usually the small type C fibers that are not myelinated. Then temperature is affected next, then touch, then proprioception, and finally motor is affected last because these are the largest myelinated nerve fibers. This is not a huge issue, but we may see some nerve blocks when they're in effect. The patient may not feel pain, and they may not even feel temperature, but they can still move that extremity. In that situation, we've achieved this block somewhere in the middle of this order of functional loss. So once again, you may see this from time to time in a patient that has some type of a local anesthetic effect or a nerve block. To summarize, what are the implications when we do see patients undergoing local anesthetic? Some clinicians do apply these drugs by these techniques of iontophoresis using electricity or phonophoresis using ultrasound energy. I mentioned that this is it's not a bad idea as long as we understand that the local anesthetic doesn't resolve the problem. It simply has an anesthetic effect. But it could help us, again, be more aggressive or try to do other procedures that would not be possible because a part of the body, a tendon or bursa, what have you, is way too painful without that anesthetic effect. So if used in this fashion, if used as a means to an end, it's not a bad idea. They are used in reflex sympathetic dystrophy, or what we now call complex regional pain syndrome, and other acute and chronic pain situations. This can be helpful. Once again, if the anesthetic is having even a temporary effect in these conditions, we can be more active. We can get the patient's extremity moving, use exercise techniques to try to restore normal function while that anesthetic is in effect, so that hopefully the original problem is better resolved, and eventually when this series of injections for this problem has ended, the patient's pain has also been better resolved. But be alert for the possible absorption of a local anesthetic into the general or systemic circulation. I mentioned briefly before that these drugs are very toxic to the brain and to the heart, and it can cause a condition called local anesthetic systemic toxicity, or as it's abbreviated, LAST. This is a huge problem. The drug should stay local, but what if it's injected really close to a capillary bed, or actually inadvertently injected into the bloodstream? This can occur. So let's take a look at some of the symptoms of LAST that we might be looking out for. So what are we looking out for that might indicate LAST? In terms of CNS effects, patients will often experience a ringing or buzzing in the ears that resembles a tinnitus. They'll become agitated, restless, which could even progress to seizures. They'll have a decrease in sensation in their tongue, their mouth, and certain areas of the skin. And in later stages, it goes in the opposite direction. The CNS gets depressed. Patients become somnolent, which could progress to coma. Respiratory depression and failure can also occur. Cardiac effects: the heart will slow down, become bradycardic. Some other ECG abnormalities, other arrhythmias may emerge. We can look for clinical signs of cardiac depression. Patients all of a sudden are becoming very fatigued, they have no energy, and become dizzy when they stand up. And can, in severe cases, this can lead to cardiac arrest. So we're watching for these signs if a person is receiving any local anesthetic, but especially during some of these continuous nerve blocks where the drug is being applied now for a day or two at a time, and it's finding its way into the systemic circulation for some reason. So that concludes our discussion of anesthesia. We started out by saying we have these general anesthetics that can be very helpful during some pretty major surgeries, and then we have these local anesthetics that can be very useful in more minor procedures or whenever we want to just anesthetize a certain part of the body. And these drugs can be very helpful in terms of how our patients are responding to physical therapy, or how that we can use some of these more advanced surgeries to replace joints and to do other things that allow our patients to then become engaged in what we do as physical rehabilitation experts.